Hi, my name is Jacob Perez, and I am a Carroll University athletic training student. For my EPR Ignite style presentation, I will be talking about the clinical significance of special tests for ACL tears. The clinical problem is ACL injuries are commonly seen by healthcare professionals, especially athletic trainers, so they need to know how to properly diagnose them and when to refer them for imaging when an ACL injury is suspected. Clinical or special tests are used for clinicians to diagnose ACL tears, and some are more accurate than others. ACL tears caused by excessive anterior translation of tibia can occur with a contact mechanism like a tackle, but it is usually non-contact like sudden deceleration or a landing and pivoting maneuver. Signs and symptoms of an ACL injury. The patient may hear an audible pop at the time of injury. The patient will have difficulty with attempting to fully extend the knee, especially weight bearing, so limited range of motion. Pain and intra-articular swelling is present. Timing is very important when using these special tests. A special test should be performed immediately following an acute ACL injury, and recovery of an ACL tear varies depending on the individual, but it's usually 6 to 9 months for athletes. Anterior Lockman's test is performed with the patient's knee flexed to 20-30 degrees. One hand is placed anterior on the thigh and the other posterior on the upper calf with the thumb on the tibial joint line and pull anterior. A positive test will show anterior translation of the tibia or an absent soft endpoint. If firm resistant uh, if firm resistance of anterior translation is likely that an ACL injury is absent, it is critical for a patient to be able to relax upper leg musculature. The Lockman's test is the most accurate test. It is highly accurate when performed correctly, and it is the most used and reliable test by clinicians due to the accuracy and the ease of use. The anterior drawer test is performed with the clinician sitting on the foot of the affected leg while the patient supine with hips flexed to 45 degrees and knees flexed to 90 degrees. The clinician grabs the tibia with thumbs placed on the anterior aspect of the tibia and pulls anteriorly. A positive finding will show that the tibia translates anteriorly and the endpoint is absent or softened. When in pain, the patient may present with muscle guarding from the hamstrings. Results not always conclusive due to the functional limitations of the knee from the swelling and the pain that can prevent correct patient positioning, and it is inferior to the Lockman's due to the decreased reliability because of this. For the pivot shift test, the patient is supine and the clinician grabs the ankle with one hand and the proximal portion of the upper leg with the other. The leg is lifted about 30 degrees of flexion with the knee fully extended and the foot rotated immediately. A valgus force is then applied at the knee and the knee is slowly flexed. A positive finding will show posterior translation of the tibia on the femur and is harder to perform, and there are contradictory specificity and sensitivity results, so it is inferior to the other tests because of this. The lever test is relatively new compared to the others, and is performed with the patient in the supine position while the clinician places a closed fist on the proximal third of the tibia and pushes down on the distal third of the femur. The lever test will show a positive finding when the foot does not lift off the table, and a negative finding when the foot does lift off the table. When it lifts off the table, it is due to anterior translation of tibia and femur, and it is easy to perform, so it reduces the margin of human error. The effectiveness of these tests need to be known by the clinicians performing them to ensure that they are practicing the best primary care. Based on the multiple studies, the Lockman's is the best special test and the go-to test when testing a patient for an ACL injury. Given the difficulty of performing the pivot shift test, it should not be performed by clinicians that are not comfortable properly performing it. The lever sign test is still new in comparison and cannot be heavily relied on due to lack of effectiveness with studies. Clinical bottom line. Overall, it is recommended to use multiple special tests when diagnosing ACL injuries to determine if the findings are consistent with each other and to increase the accuracy of the diagnosis. Always compare bilaterally to make sure. Whenever any special tests come back with positive findings of an ACL tear, it is very important to refer the patient to imaging because an MRI is the criterion gold standard test for diagnosing ACL tears, and it will be able to show other structural damage to the knee that is present. Here are my references. Thank you all for listening, and I appreciate it.